Assalamu alaikum. My name is Rabi Afzal. I am from 4th year morning and my roll number is BP 1650178 and my topic name is Atherogenic Dyslipidemia. So, what is dyslipidemia? Dyslipidemia are disorder of lipoprotein metabolism, including lipoprotein overproduction or deficiency. This disorder may be manifested by the elevation of the serum total cholesterol and low density lipoprotein cholesterol and triglyceride concentration and a decrease in the high density lipoprotein cholesterol concentration. Classification of dyslipidemia: primary and secondary. Primary familiar dyslipidemias and secondary which we acquire. Why we have a strong concern about dyslipidemias? So, there is a strong relationship between elevated serum cholesterol level and the coronary heart disease. Coronary artery disease yet remain one of the major killer in current society. Dyslipidemia causes primary and secondary. In primary, there is overproduction and defective clearance of the cholesterol TG and LD is the result of the mutation of single or multiple genes. The primary disorder are the common dyslipidemia causes to the children, although it may not affect in the most cases of adult dyslipidemia. But in secondary, adults are the most effective ones. The causes contribute a lot on how an adult will be affected with dyslipidemia. The major causes is lifestyles. The lifestyle includes excessive intake of cholesterol, trans fats, and saturated fats. Trans fats are the fatty acids that are either polyunsaturated or monounsaturated, in which there we added hydrogen atoms. Trans fats are usually used in a lots of foods. Other secondary causes are uh, alcohol, inactivity, diabetes, hypertension, chronic kidney disease, low HDL, age and gender, drugs use. Risk factor is family and food. Dyslipidemia symptoms. Dyslipidemia does not have symptoms at all, but it can cause other symptoms like coronary artery disease. And there is a xanthomas at the elbow, hand, knee, feet. We have a हमारी आईलेट के ऊपर जो है वाइट वाइट लिपिड्स जमना शुरू हो जाता है, दाने दाने जैसा वाइट वाइट नज़र आने लगता है हमारे फिंगर्स पे, हमारे हैंड्स पे. तो ये इसकी सिम्टम्स हैं डिस्लिपिडीमिया की. TG levels and HDL levels. High triglyceride levels are also associated with increased risk of cardiovascular disease. Normal ranges is less than 150 mg per dl. Borderline range is 150 to 199 mg per dl. High range is 200 to 499 mg per dl. Very high is greater than 500 mg per dl. Now come to HDL level. A level greater than or equal to 60 mg per dl is excellent. While level of HDL cholesterol less than 40 mg per dl, lower than desired. Now come to the case study of atherogenic dyslipidemia. Case study. The patient is a 58-year-old who is male. His height is 70, weight is 202, mass index is 29. The patient is overweight. He also has waist circumference of 40. His cardiac exams and peripheral pulses are both normal. The patient medical history is significant for hypertension, for which he takes lisinopril and HCT set. His blood pressure on medication is 130/80 mg/Hg. He has a significant family history in that his father had HTN and died of a myocardial infarction at the age of 72. His mother is 74-year-old and was diagnosed with type 2 diabetes. She has peripheral neuropathy. His sister is 50 years old and has HTN and history of gestational diabetes. The patient is married with no children. He has at least two conventional risk factors, HTN and low HDL-C, and his Framingham risk score is 11%, which places him at moderately high risk in primary prevention. Now we prepare soap notes. Subjective physical exam find gender is male, height is 70, weight 202, BMI 29, BP 130/80, weight circumference 40, cardiac exam normal, peripheral pulses is normal, No organomegaly. History. Father with HTN died at the age of 72. Mother diagnosed with type 2 diabetes for 16 years and has peripheral neuropathy 74 years. One sister 50 years with HTN. Married, no children. Never smoke, exercise irregularly. Use alcohol on weekends. Current medication is lisinopril HCTZ 2025 mg QD. Now come to objective lab data review. FSG 100 mg per dl, creatinine 11 mg per dl, EGFR 69, uric acid 8.8 mg per dl, lipid panel TC 178 mg per dl, TG 160 mg per dl, HDL 39 mg per dl, LDLC 106 mg per dl, and non-HDLC is 139 mg per dl. A1C is 60%, US 60% without protein, TSH normal, left axis deviation otherwise normal. Now come to assessment. The full extent of cardiovascular disease risks in this patient, ATP3 risk factor and risk categories are based on rigid cut patient, thus they could change with even modest improvement in modifiable risk factor. Moreover, traditional estimate of risks based on Framingham risk score exclude a risk factor for CVD such as fasting serum glucose, triglyceride level, and waist circumference that are common components of the metabolic syndrome and other conditions. In addition, the current patient has a concentration of a borderline or risk factor that present a high likelihood of CVD events in the next 10 years. Plan and interventions. Non-pharmacological lifestyle changes, diet, fat control, exercise, diabetes control. Pharmacological therapeutic lifestyle changes are not enough. Intervention in this patient based on a broad evaluation of risk factor. LDLC lowering drug therapy should be considered. Hypolipemic medication, statin, vibrate, resin uptake. Note: in a patient of moderately high risk for MI or CHD that the update ATP3 recommended a treat to target LDL-C goal of less than 130 mg per dl with less than 100 mg per dl a therapeutic option. However, a comprehensive estimate of this patient risk suggests that a lower target of 70 mg per dl may be appropriate. Thank you so much.